Good day, and thank you for joining. I am Sherilyn Francis with the Georgia Health Information Technology Extension Center, and we welcome you to today's webinar. We invite you to connect with us at www.GA-HITEC.org and via social media at Georgia HITEC using hashtag HealthITSolutions. Georgia HITEC is Georgia's only federal and state endorsed expert to assist providers in the achievement of meaningful use using EHR technology. The Georgia Health Information Technology Extension Center is located at the Morehouse School of Medicine National Center for Primary Care. And now a few announcements. For physicians who are duly eligible for both MIPS and Medicare Incentive EHR program, the GAMIS portal is now open to accept applications for payment year 2017. We encourage you to contact your Georgia HITEC field representative or Georgia HITEC support for further instructions and help. Additionally, each second and fourth Tuesday at 12:30 p.m., we have Georgia HITEC virtual office hours. And during this time, there is a 15 to 20 minute presentation which will allow for dynamic conversation around QPP. I present to you today's webinar entitled 2017 Quality Payment Program Wrap-Up, presented by Ms. Phoebe Nelms and Ms. Liz Hansen. In compliance with ACCME guidelines, the following speakers have no financial or other relationships with the manufacturer of any commercial service discussed in this educational activity. The goals for today's webinar are to review the MIPS checklist for readiness, discuss preparation tips for planned CMS web portal attestation, to review avoid the penalties, and to discuss an overview of proposed changes for MIPS 2018. And now, Ms. Nelms.
Good afternoon and welcome everyone. We're so very glad that you could join us. And the first thing we want to get across, loud and clear, it's not too late. You can still submit your data and avoid that penalty for 2017, which will impact your payment in 2019. So you have options. You can pick your pace to avoid that minimum negative adjustment. You can submit one quality measure for at least one patient or one improvement activity, and you can score enough points to achieve a 4% positive adjustment, depending on how much data you submit. Those exceptional individuals who achieve over 70 MIPS points can qualify for a 0.5 or up to a 12% positive adjustment. And something that we really want to give attention to is the Physician Compare website, which is now up. It's, to my mind, it's kind of like the Consumer Reports for healthcare. Physicians really will begin taking note of what information is housed there, as it may impact their patients' decisions. So we said we'd like to go over our MIPS checklist. One of the first things that you'd have to do, of course, is check your eligibility on the qpp.cms.gov website, then determine which level of participation you will do, pick your pace, check your EHR certification because that will impact the measures that you will use. Something that is very important to do as the reporting portal gets ready to open is having your EIDM access. And we'll talk a little bit more about that as we move on. So for the Advancing Care Information category, be sure and complete your security risk assessment. This is a yes or no item, and it is vital that if you want to pass this category, you must complete one. And also check on your Health Information Exchange status, how you can possibly improve that. Working on improvement activities and quality measures is also part of that checklist. So under eligibility, who is included in MIPS? If you bill Medicare Part B over $30,000 per year and care for more than 100 Medicare patients and are the physician types listed on this slide, you are eligible. Potentially, but check the website. So who is excluded from MIPS? If you're newly enrolled as a Medicare provider, then you'll be exempt until the following performance year or if you fall below the dollar amount or number of patients, or if you significantly participate in an advanced APM, which means you would receive 25% of your Medicaid payments or see 20% of your Medicare patients through an advanced APM. So here is the website where you can enter the clinician's NPI number and find out if they are eligible to participate in this program. This is what it looks like. Now, this is only one result. There may be additional results. As we can see here, that clinician was not eligible necessarily as an individual, but I'm sorry, this one is where an individual is eligible both on their own merit and because they are part of a group that meets the threshold. So you want to be sure that you scroll through the entire eligibility page because you are responsible for submitting for each TIN that you're eligible under. The exemption status can apply to one TIN, TIN, tax ID number, and not to another. So if you're not eligible as an individual, but you are as a group, be sure that you check with the person that will be submitting data for that group to make sure that you are covered to avoid the penalty. So we have several options here to pick your pace. The one being not doing anything. And that's not a good plan because it may impact your payment in 2019 negatively by 4%. The other option is to do a test, and this is to allow for flexibility since it is a new program to get everybody's feet wet, and you only have to, as we said, submit one quality measure by the deadline of March 31st. Or some people who got ahead of the curve submitted data for 90 days. They're ready to submit 90 days worth of data, and they may earn a positive payment adjustment or even earn the maximum adjustment. And there's the full year of 2017 data that can be submitted to Medicare, and that would also put you in line to earn a positive payment adjustment. So I have a question here I'd like to get your input on, please. So how do you plan to participate in MIPS? And if we could get your input, that would be wonderful because this helps us adjust and adapt and provide the resources that you will need to be successful as the program continues to mature. So we'll just give you a few minutes, still getting a few results in. All righty. Thank you so very much for your responses. And with this, we are at a good stopping point for me, and I would love to turn this over to Liz to continue to provide us with the nitty-gritty of MIPS participation.
Thank you, Phoebe. We did see from that poll that many of you, or the majority of you on this call, are submitting for at least a 90-day. For those of you that said you were not participating, if you are eligible and feel like you can't participate, we'd love for you to let us know, see if we can give you some help. So we are going to continue to go through these checklist items. I do want to say that I know there's a lot of slides here for you. We won't spend a lot of time on every slide. Our goal was to give you some information so that when you could use it as a reference, because these slides will be made available to you. So if you're wondering why there's so many slides, we just wanted to make sure we covered as much of the most critical information as we could. Now we're going to talk about EHR certification, and your EHR certification has to be either a 2014 or a 2015 certification to participate in the 2017 ACI component. Your certification can totally impact whether you can meet the Advancing Care Information Component measure, and of course this measure counts for 15% of your MIPS score. Your certified EHR will dictate which measure sets you can use, and it can impact whether you have access to your MIPS dashboard or scorecard. The reason I say that is some of you still have a 2014 version, and you don't have a MIPS scorecard showing up on your system yet. And for those that fall into that category, we're working through using your meaningful use report to get the information that we need. So we can still get the information even if you don't have a MIPS scorecard. Most of you will use the transition measures for advancing care information, and that is the 2014 certification. Would require you to do that. If you have a 2015 certification, you can still use those transition measures, and most of you would find those a little bit easier to use. Did want to point out that you can still participate in MIPS even if you do not have an EHR. Not the ACI component, but the other two components you can still participate in and work to avoid or minimize any penalty. Now we're going to talk about attestation methods, because we did say that you need to choose a reporting option. Many of us are still in flux about which method we want to use. Some of you are waiting till others of you have gone ahead and attested through one method or another to see how that works. We can only stretch that out so far. But if you are an individual reporting, you could report through claims-based for your quality measures. You can go through your EHR, which you need to investigate. If that's what you plan to do, you need to make sure your EHR can do it, and two, you have everything that you need to do it through your EHR. You can use a clinical data registry, or you can use a qualified clinical data registry. And then we will have available the CMS web portal. We anticipate this being available the 1st of January for pieces of your individual reporting. If you are reporting as a group, you cannot use claims-based reporting. You can use, a group is classified as 2 or more eligible clinicians. A physician in the group may choose to participate as an individual under MIPS or to participate in the group. If the practice has decided to use the group methodology, everybody needs to follow that format. You can't use, one person wouldn't choose both, and one practice wouldn't choose both. For your reporting options, you can go through your EHR if it's available. Folks, a lot of EHRs do not have this available yet, so you need to just do some homework and find out. You can use the clinical data registry. Many of you are very familiar with these data registries because you use them for PQRS reporting. So it's a similar methodology and similar cost. You could use a qualified clinical data registry or the web interface solution. The web interface solution is only available to practices that have 25 or more eligible clinicians, and you would have already had to have signed up for that option before now. So it's too late for 2017 to sign up for that web interface group reporting option. So here's just some more detail on what each of those methodologies mean. One of the big things we will make sure you remember is, claims can be a wonderful and simple solution for attesting, especially for 2017. You can report through claims, through the claim submission process for the quality measures, and then you can go on to the web portal that is new to attest for your advancing care information and for your improvement activities. So you've got a little bit of flexibility there. If you use the qualified registry, I would recommend that you do everything through that qualified registry. The same would be true of the EHR reporting. But again, if you're claims-based, we may want to talk about which method you're going to use for reporting your ACI and your improvement activities, because you got a little bit of work to do there to access that CMS portal. And I do want to point out, I think I do point it out somewhere else, but I do want to point out that the quality scores will probably differ based on your attestation method. Typically you find that the highest scores come with your EHR submissions, the middle score would come with your registry submissions, and then the lowest comes with your claim submissions. But again, I would submit to you the claims methodology may be the most controllable and uses the most controlled data set. So it's just an idea there. And then again, this has the same data, just sorted out differently, just for you to come back and look at if you need to. So I do want to remind you, if you're reporting through your EHR, you do have to have certified EHR technology, and they have to have available the reporting mechanism for MIPS, and not all do. You do have to have an EHR for advancing care information, that component, but you don't have to submit through your EHR for that component. You can use 2014 or 2015 certification to do your reporting, and you can get additional bonus points for EHR technology, and I just mentioned that on the quality side. So we do want you to talk with your EHR vendors, find out if they have attestation through them, and you also want to look at the cost, because the vendors that do have this, many of them are charging extra for you to submit through them. And some of them are requiring some additional pieces. Some require that you have EIDM access. Some require that you can generate a QRDA report. So there may be some other requirements you need to make sure you've got under control before you determine how you're going to attest. If you're choosing the qualified registry route, or if you're choosing the registry route, here's a link to the list of registries that are available. And here's a sample of the page that you would go to for those resources to see what registries are available. There is a document called 2017 Qualified Registries, and you would download that particular document. And it would look similar to this. And the neat thing about this is it does tell you what quality measures can be submitted through this registry. You may want to choose one that can take all your quality measures, because most of you don't have a lot of flexibility in choosing your quality measures. You have a limited data, you have a limited set in your EHR, so you want to make sure you use one that can take the quality measures you've done. You also want to see if they can accept advancing care information or improvement activities in those registries. And you'll see over in that third column that you have the cost of these submissions. And I think that's included on all of the registries in this very long document that gives you lots of options. Now we're going to just do a pretty quick overview of the components of MIPS: quality, improvement activities, advancing care information, and cost. For 2017, quality will count towards 60% of your total MIPS score. And of course, it replaces PQRS that many of you are accustomed to. The improvement activities account for 15% of your total MIPS score, and this is a new category. Your advancing care information replaces the Medicare EHR incentive program, also known as meaningful use, and it accounts for 25% of your score. And then for 2017, cost is not a measure that we have to be concerned about as far as your MIPS score. It's time everybody start thinking about that for 2018, but it is not something we had to worry about for 2017. So as we take a look at each of these components, going to do just a quick overview. 271 measures available for the quality component. As many of you know, you don't have 271 measures available on your EHR. So although there's 271 available to everyone, that's probably not what you can report on based on what's available in your system. This will, oh, there's a typo. It will count for 60% of your total MIPS score. I apologize for that. You'll report 6 measures that best fit your practice. You will include 1 outcome measure. If you have no outcome measures in your quality measure set, you would select a high priority measure. And there are several that are pretty generic that almost everybody is doing, so I don't think that's going to be a major concern. It's just something on your checklist. You want to make sure you have a denominator of at least 20 in the particular measures that you pick, and that 50% encompasses 50% of your patient population. And most of those of you that are participating in ACO, your ACO typically reports quality measures for their members, so you want to find out if they are doing so if you are a member of an ACO. How do you know what your quality measures are? What measures are available to you? Now there is a place on the qpp.cms.gov site that has the quality measures available to you. You can sort by specialty set. You can look for high priority measures. You can look for data submission methods that are available for each set. So we do want to recommend, if you don't know which quality measures that are best for you, you might want to see what's available. I do caution you, many of them are not going to be available on your system. And of course, we do want to tell you that You may determine that you want to use the 6 best scoring quality measures, or some of you have suggested that you're going to back off and not quite use all of your best, so you have some room to improve next year. Most of you, however, are trying to get the highest score you can because you want that exceptional clinician additional payment adjustment, upward payment adjustment. So this is just a look at the quality pages on the QPP website. And again, you can sort by numbers, you can sort by names, lots of ways to get around in this area. Caution you again, make sure that they're available on your system, your EHR system. Here's a look at when you actually look into or use the drop-down caret for a particular measure. It tells you whether it's intermediate, it tells you whether it's outcome-based, whether it's high priority. It gives you a variety of numbers that are used for reference purposes. The reason we point this out to you is some EHRs use the CMS number, some EHRs report with the NQF number. I haven't seen a one, I don't think, that uses the quality ID number, but the quality ID number is the one we need to use to look up scores on the decile report if your system doesn't do this automatically. So let's go forward with that. You can look at your MIPS quality report to see what your best scores are. You can review your QRDA report. It's a lot easier to read a MIPS quality report than it is a QRDA report by far, but you could certainly do that. Some systems only generate a QRDA report, and that's why I bring that up. Then you want to cross-reference your scores with the decile report. Now, if your system has been updated so that it gives you a MIPS scorecard and it provides you with the estimates of the points you'll get for your quality measure, fine. If it does not, and many do not yet give you those points, then you can get a good guess estimate of your points by going to a decile report. So we do want to remind you your measures are going to differ. The scores will differ based on how you are submitting, whether it be through claims, EHR, or through a registry. And we did tell you that the EHR submission method does typically yield the highest scoring opportunity, but is probably the least available to most of the folks that we work with. Now here's a sample of a quality dashboard. It is just one sample. Each different EHR, it looks different. Actually, this one is horizontal. Most of them are vertical. So regardless, this is an example of where you see a performance rate, you see a numerator, you see a denominator, and you see if there's any exclusions or exceptions. So this performance rate is the number that we actually use when we look it up to see what the score will probably be using the decile report. The decile report is available to you through the resource library, and here is the link to the resource library. It used to be on the QPP site. They've moved those away. That was kind of a bummer because it moved it to a different place, but the link is quick to get to, and these are actually sorted. So it's easier to find what you need once you get to this page. Once you've downloaded that quality benchmark, you can take your percentage from your report for flu vaccinations, for example. This one is 85.2. And then you can look up which number that is on the decile report, and it's number 110. And then on that benchmark, I call it the decile report, it's called the benchmark report. Then you can go to measure 110, which is screening for influenza, and you can see the different amounts that would apply to which percentile or which decile, and you can see how many points. If you have over 79.02, you're going to probably get 10 points. If you're for 74.28 to 91.83, 9 points. That, depending on how, for that same date, for that same amount, based on doing it for an EHR versus through a registry, and then of course the claims gives you a little bit lesser score with 8 points. So you wouldn't score all three of these ways, folks, although I do have some of you that have mapped out all 6 measures all 3 ways to prove to your doctors what the best way and the most cost-effective way would be for you to attest and get the highest scores. So we have had a lot of folks play with these numbers, but the point is you take your percent, then you come over here and pick under submission method which submission you'll use, roll out to see where your percent falls, and that decile is the estimate of the points that you would get. Again, all this is walked through on this slide for your future reference. Improvement activities. So this is a new performance category for 2017. There are 93 measures. It accounts for 15% of total MIPS scores. We do want to let you know that many ACOs are also taking care of the improvement activity portion for you as well as the quality. If you are in an ACO, please make sure you know what they're reporting for you. So here's just a few bullet points that we wanted to go over about your activities. You do want to review and select activities that best fit your practice. Many of you have been doing improvement activities, but not in a formal manner, so perhaps you just didn't realize that's what you were doing. Again, that's something we'll be glad to talk with you about. If it's groups of more than 15 eligible clinicians, then you would attest that you've completed up to 4 improvement activities. You might do 2 high-weighted activities, or you might do 4 medium-weighted activities to meet this requirement. Most of them are for 90 days. However, there are a few that are for longer than 90 days, and you need to find out. I'll show you how to do that in just a minute. For groups of 15 or fewer, or if you're in a rural or health professional shortage area, you attest that you've completed up to 2 activities for a minimum of 90 days. That's 2 medium-weight activities. You may choose to do 1 high-weighted activity, although those do tend to be a little more difficult. Participants in Certified Patient-Centered Medical Homes, or PCMH, or comparable specialty practices, or an APM designated as a medical home model, you automatically earn full credit. For participants in certain APMs under the APM scoring standard, such as the Shared Savings Program Track 1, you will automatically be scored based on the requirements of participating in the APM. All current APMs under the APM scoring standard will be assigned full credit. If you don't know, and folks, this can be confusing. If you don't know, then approach your APM administration to inquire, or get with us and see if we can help you figure out which of these applies to you. If you're in any other APM, you would get half credit. So this can be very confusing. APMs are a bit more sophisticated, so ask for help if you don't know which one applies for you. There are flexible data requirements, as I just pointed out, for small practices, rural locations, health professional shortage areas. We've got the 2 medium weights and 1 high weighted components that you would do, activities that you would do, instead of the 4 that are required for larger practices, and that's awesome. So let's take advantage of that, but be prepared to do some new ones if you can for next year. On the qpp.cms.gov website, you can take a look at all 93 of the activities. And once you look at these activities, you want to go find out, once you've picked a few that you think might work, perhaps pick 4 if you only have to do 2, and investigate them, do a little research. Then you would go to that resource library, look at that MIPS data validation criteria, because you want to find out what type of documentation you need for this activity, and remember that you're going to save these for 7 years. Now here is a sample of what this document looks like. It is a spreadsheet and it is very busy, and for that I apologize, but once you start using it, it becomes a little easier. It does give you the activity name, the activity description. And folks, please read the entire description. I've had many folks, for example, say, oh, we're going to do the tobacco improvement activity because we do that. We do that all the time, and we've got a report that shows that we do it. And then I have to call attention to the fact that that particular activity requires that the participants or the patients that you use for that activity must have a behavioral health issue. So that totally changed that ball game for folks because they weren't keeping up whether they were being co-managed for behavioral health. So it's very important that you read these requirements and the description so that you understand exactly what it is you're supposed to be measuring. And then under the column G, we have the suggested documentation. Folks, if they suggest you have this documentation, then have it. Save it, keep it, be ready for an audit for the next 7 years on this particular 2017. So make sure you've got it somewhere safe and that others in the practice know where it is, because we don't know when you might get audited. We're just assuming they're going to take place, and you will need to prove that you actually did the improvement activity. The good news is the proof should be sufficient through your documentation. And so one of the tools that we use, and our mothership, as I call it, Alliant Quality, who has been working with quality improvement for several years in the state of Georgia, has provided us with an improvement activity document, and this is to use for a plan, do, study, act, change management. It's very simple to use, and we'll be glad to help you out. But we want to make sure that you fill out this document for every improvement activity. You customize it for the activity that you're doing. This is just a sample. And then you fill out what actually happened when you did your activity and how the measures differed from what you thought they would and what you would do differently next time. So it's something new that you may not have done before, but this is fairly easy to do, and we'll help you work through it. But we do recommend you use some type of change management document like this to help prove that you actually did the activity and that you had a plan. Oh, I clicked the button too many times. Sorry, folks. So we do want to point out, as we have already before, that as we begin to talk about advancing care information, that your measures are dependent on your EHR certification. Almost 100% of the folks that I work with are using the transition measures, which can be used with a 2014 certification or a 2015 certification. So we might encourage that you use those because they're just a little more simple. If you need some advice on that, we'd be glad to pitch in. Now, this is a list of the 2017 transition ACI measures. There are 11 of them. And as you can see, you can go to the QPP website and get some definition around each of these measures. That good QPP website, we love it. Here's just a little sample that we put together just to remind you that the base score is required to get any ACI points, and it will give you 50, or you get a 0. And if you get a 0 because you didn't do one of them, then you will not get any ACI points. Now, there's been a tweak to this recently. We're going to talk about this at the end of the session. But for right now, we just want to make sure that you get at least one of each of these measures done. As we've talked on many webinars before, that security risk assessment has been, for meaningful use, was the biggest reason people did not pass audits. So we want to make sure you've got that security risk assessment done, has a mitigation plan, and you've got dates on your mitigation plan. That risk assessment needs to be done prior to or during your attestation period. The net of this is, folks, if you haven't done your security risk assessment for 2017, you got to get it done before the end of the month. Then we have your performance activities. And your performance measures are based on the percentage score that you have on your report. For 2017, patient access or portal is doubled, and the health information exchange measure is doubled, and we really like that. Otherwise, then we match up with this little table we have on the right. If your performance is between 1 and 10, you get a point. If your performance is between 31 and 40, you get 4 points. If it's between 41 and 50, you get 5 points. So if your system does not automatically give you a point score, then you can look up your score based on the percentages on your report, which will be there. And even if you're having to use a meaningful use report, you can use those percentages just ignore the thresholds. Had several people get concerned about those thresholds. If we're doing MIPS, other than meeting these base requirements, the thresholds are meaningless to us, but the higher the points, the better the score. Now we're just going to take you through a look at a couple of dashboards. This particular one actually has the percentages and gives a score, which is kind of neat. It doesn't have a numerator and denominator, which I like, but it sums it all up for you, so I shouldn't whine about that. And it gives you a total performance score. Notice this particular individual has an ACI score of 111. Only 100 points will count. So this is a pretty good score and a pretty good system for reporting. Most of you do not have something like this. Here's another example of an ACI transition measure dashboard. As you can see, it does not give us the finished points. You'd have to calculate those yourself using that table we had a couple slides ago. Let me just point out, though, that in this particular example, I'm going to skip right over that HIE because we ought to have a 1 in that numerator. We don't. But for medication reconciliation, they have 100%, so they'd get 10 points. Patient electronic access, they'd have 9 points normally, but it's doubled, so they'd get 18. View, download, and transmit, that's actually a pretty good view, download, and transmit number. That 18% would give us 2 points. The next one, 21%, that's above 21, so we're going to get 3 points for our patient education. And that secure messaging is not up to stuff. So you can do an estimate of what your score is based on these percentages. Again, if you need some interpretation assistance, we'll be glad to help. Now, I chose this particular slide, not that I'm going to go over every one of it, but it might be helpful for those of you that are using old systems to realize that if you, and I don't mean old systems, forgive me, if you're using meaningful use reports rather than a MIPS report, please remember that there are several items that we would pay no attention to. And I have an example of those marked out on this document. You would use that 2017 transition measure set and use only those measures, matching them up to your report. Here's another example, and I've just mapped out what those scores would be just so you can see. So and there's another example. So we haven't met one we couldn't figure out or estimate what your score is going to be, but it's just not always self-evident. You sometimes will need some help. So now we have a polling question. Are you ready to report from MIPS? Yes, no, hope to get there. I have to tell you, I had a whole different response for number 3, and they changed it. But mine might have been a little more colorful than hope to get there. So let's see what we've got on that. Look at you folks that are ready. I'm proud of you. If you're not ready, make sure that we're talking to you. Make sure we're giving you some help if we can, please. We appreciate your participation and hope you will have some questions for us or some discussion at the end. Now I just want to take a few minutes to go over some of the QPP Year 2 final rules that were recently announced. These were released for comment on November 2nd. The document was 1,653 pages long, but for those of us that read it, that was less than the original or the 2017 rule, so we were glad that it was less pages. And there's a comment period through January 1st. We anticipate that the rule is going to be executed as it was released. Something could happen before with the comment periods. We do anticipate these will occur, though. So some of the highlights: the low volume threshold for MIPS exemption in 2018 becomes 200 Medicare patients, and Medicare reimbursement threshold of $90,000 in Part B billings. So rather than 100 Medicare patients and 30,000 Part B Medicare billings, the threshold has moved to 200 Medicare patients and $90,000. So this is something you want to make sure. We've already told you need to check your eligibility again for 2018 because it can and will may change. But now you know that it may change more than you had anticipated. So again, don't guess. Don't even depend on your internal reports. Check the eligibility site that Phoebe shared with us at the beginning. You will be allowed to have virtual groups. We will have a session later on in 2018 about virtual groups, what the benefits are, how to determine whether you would want to use a virtual group. Don't quite have enough time today to go over them, but we will spend more time on those. Probably the first time we'll share them will be in our biweekly, our Tuesdays that we have our virtual office hours. We'll probably go over it then, and then later in the year we'll probably cover some additional on a 1-hour call. One of the other things I want to point out to you that the adjustment, the payment adjustment, positive or negative for MIPS, will apply to Part B drugs. There were many folks that contested this. I hope that it would not happen, but it did. And as many of you know, if you utilize Part B drugs within your office, those are expensive. And so to have the adjustment applied to those could be incredibly significant for your practice. So make sure you take that into consideration as you move forward. I do want to just point out to you that there has been a shift in the category weights for 2018. You'll see that in 2017, quality was 60%, and we had no cost component. In 2018, quality will account for 50% of your MIPS score, and we will have a 10% cost component. So that has changed for you. And we will go into more detail in a later session on that cost component. So some other changes. CMS will provide 3 points even if small practices submit quality measures below the data completeness standards. And this may be important to many of you. I've had many specialties that are in small practices that can't find 6 quality measures that are above the threshold. So this would be a very good thing for you. It raises the minimum point requirement from 2017 at 3 to 15 to avoid the payment adjustment. And folks, the payment adjustment that goes with your 2018 attestation applied to 2020 is a plus or minus 5%. So this goes up from 4% to 5%. That will go into effect on your reimbursements for 2020. Also, in reference to recent natural disasters, the final rule automatically will rate the quality advancing care information improvement activity performance categories to 0% of the final score for clinicians that were impacted by Hurricanes Irma, Harvey, Maria, and other natural disasters. So it would be dependent on whether you were declared a disaster area, and then folks, it also should be dependent on whether you need to use it. Most of us were inconvenienced for a few days. A few of us were inconvenienced for a week. Did that really keep you from attesting for MIPS? So I would like you to give a little thought to that before you think to take advantage of the natural disaster component, because it is available for those in Georgia that suffered through the hurricane. There is a significant hardship exemption available in the Advancing Care Information Performance category for MIPS eligible clinicians, and we will talk about these hardship exemptions in more thoroughly at a future date. Physicians in small practices, 15 physicians or fewer, can earn additional 5 points if they submit data on at least one quality performance category. So that's another benefit that will be applied to small practices. And so most of you on this call are going to, if not all of you, will be able to benefit from that. And you will be able to earn up to 5 more bonus points if you treat especially complex patients as defined by those hierarchical condition categories, the HCCs. And so that may be something you want to do a little bit more research on if that's something that might apply to you in 2018. Now your components, quality will be 50%, improvement activities 15, ACI 25, cost 10. Your quality measures will be the same basic requirement, 6 measures to include 1 outcome or 1 high priority. You may see these quality measures change over the next few months. CMS is proposing to score any measure that does not meet the threshold at 1 point, and for practices with 15 or fewer, 3 points. So that's really big for some of these small practices, especially specialists. You will have to have a 365-day reporting period for 2018, folks, so that's a little different. And what that means is you need to start paying attention to those quality measures a little earlier than you probably did this year. And then the threshold for performance has been raised to 15 points from 3 in the previous year for those point accumulations. For ACI, we will maintain the flexibility measures, so that's super, super good news. What this means is that you can use the transition measures again in 2018. And although most of you are going to get your upgrades and you're going to have those 2015 measures, you may still find in 2017 it will be easier to work with your 2017 measures, but you can use either or if you have that 2015 certification. There will be bonus points applied if you use a 2015 certified system. So that will be good news for some of you. Many of the folks I work with will not use the 2015 certification. You can report for 90 continuous days again, or up to 365 days. So again, for quality, you will have to report for 365 days. For ACI, you can do 90 days or anywhere between 90 days up to 365 days. So a little different and a little more flexibility. And there's a new exemption proposed. We're very excited about this. For physicians who do not write 100 eligible prescriptions, you can get excluded from the e-prescribed measure. The e-prescribed measure is for ACI a base requirement, and so this could make a difference. Now, I got to say that the folks that I work with all have something in the numerator for e-prescribed. Well, no, that's not true. I do have some folks that are split between hospitals, so that's not quite true. But most of you on this call do have some e-prescribes. Perhaps the more important note is that those with less than 100 eligible referrals or transition of cares during your attestation period can get an exclusion from that base requirement. That's huge, you guys. That's huge. So again, if you report on a year, it's probably going to be more than 100 referrals. So this one may force you, if you have to take advantage of it because you couldn't get that HIE done, like force you into using a 90-day. And that's something we can look at the end of the year after you finish getting all your data in. We can look in early January, see how you're sitting, make some decisions. And there will be a readjustment so that physicians who cannot report immunization registries are not disadvantaged. So we'll see how that actually comes out. Improvement activities, basically the same requirements, so we're still going to get those flexibilities if you have 15 providers or less to do the 2 medium weights or 1 high weighted, so that's outstanding. That's very good news. They are finalizing 21 new improvement activities and will be making changes to 27 previously adopted activities. So you just want to make sure that what you choose to use is in the new option set. So here's that checklist again, and here's our question. Are you ready? Do we need to do some more to help you? Are you ready? So with that said, Phoebe or Sherilyn, I guess we're ready for questions.
Thank you so much, Liz. I would love to read the questions. However, they are not visible to me at this time. I do have some. One question was, do you have any preferred resources for a quality improvement team? Their EHR vendor recommends doing this as it covers a lot of the improvement activities categories. So you did mention in the presentation that Alliant Quality, as our state's quality improvement organization, and who we are partnering with to provide the support to small practices, they do offer assistance in doing improvement activities, such as depression screening and tobacco use, unhealthy alcohol use, and things like that. And the contact information was kindly provided in an answer in the chat box.
Thank you, Phoebe. We might also mention that there is an initiative called TCPI, Transforming Clinical Practice Initiative. There are a few groups that are offering that assistance in the state of Georgia, and you can go on to, you can look up TCPI and get access to which of those are available. We can't necessarily recommend one over the other in the state of Georgia, but they do come in and focus on practice improvement and can put you through the paces to get many improvements done within the practice. So if that's something that you'd like to consider, we'll be glad to provide you with a link and to encourage you to investigate that method. It does take a commitment from your practice, but many of you are very committed. So if that's something that you'd like to pursue, we would recommend that.
Excellent suggestion. For those who wanted to have access to the presentation, it is available to download, as you can look at the left bottom portion of your screen. An additional question. Sorry.
No, go ahead. I was going to read it. You go ahead.
Oh, okay. Question in the box. If you belong to an ACO and are PCMH, what exactly do you have to report?
So that's a great question, and I'm excited to hear we've got some PCMH participants on the phone. We'd like to have more of those in Georgia if we could. So if you are part of it, PCMH does take care of your improvement activity portion. So typically if you were PCMH, we would say quality and advancing care information. However, if you belong to an ACO, they are probably submitting your quality measures. So we need for you to inquire with your ACO and ask them what they are submitting for you. I would also like to add that if you are an ACO, you need to find out if they require that you submit your advancing care information as a group, because some ACOs do have this requirement. It's something recent that we just discovered. So if you're an ACO, find out what they will report for you, what they want you to report, and see if it's okay if you report individually for ACI or if you need to report as a group. Typically PCMH, quality, and ACI. If you're an ACO, though, typically only ACI. I hope that answered more than it confused. What else do we have?
Is it better to use the CMS portal for attestation or another vendor?
Wow, there's a $50 million question.
There is.
Well, I have to say that I'd like to save my judgment on this until I actually use that web portal. In the past, I've always been a big proponent of using the web portal for attestation. However, we haven't had an opportunity to use it yet. We're going to get some exposure to it really soon on our support end, and then perhaps I'll be better prepared to give you my opinion. But if you want to go the easiest route but the more expensive route, that would probably be your registries this year if you didn't submit claims-based quality measures. If you submitted claims-based quality measures, you will want to use that web portal. That'll be inexpensive. Hopefully it'll be easy to do. And you give us a few weeks using it, folks, we'll probably be good at assisting you with it. But we haven't seen it ourselves yet. So again, if you're doing claims-based quality measures reporting, you're going to probably want to use the portal. If you can use it through your EHR, many of you have expressed concern about that because, again, it's new to you this year and new to your EHRs. And most of those folks have decided that they will pay to use a registry. So it depends on what you can afford, what will be easiest, and we'll be glad to talk to you individually about those needs. Now, Sherilyn, before you go forward, I see that we've got a question on when is the CMS portal available. It is scheduled to be available on January 1st. We have another question. Oh, that one's not in my ballpark. The download button is not enabled. You got me on that one, Marlene. Sorry. Sherilyn, I'm going to let you rock with that one.
Okay, that I'm not necessarily that great with download button issues, but we can work on that. Oh, I'm sorry. Is it the download button for the website? Okay, it's been resolved. Wonderful. Great. So all you have to do is click on the actual file and you should be able to download it. Additionally, for those who were asking for recordings of past Georgia HITEC webinars on QPP, all you have to do is select the Georgia HITEC webinar recordings under the Web Resources pod.
We did notice that today on the QPP website, there is now a tab for the portal for attestation. Now, folks, don't go bogging it down, not being able to get in anywhere. As soon as we can play around with it, we're going to do that. And you will notice that that does require your EIDM password and login. So please make sure you get that before the end of the year. Don't wait until January when everybody in the country just discovered that they need it and is trying to get it. It is not a 10-minute process. Thanks, Sherilyn. Sorry, go ahead.
My pleasure. Thank you, Ms. Hanson and Ms. Nelms, for an extremely informative and engaging presentation. You two worked magic. Additionally, as a reminder, the GAMIS portal is now open for all physicians who are duly eligible for MIPS and the Medicaid EHR Incentive Program. We encourage you to contact your Georgia HITEC field representative or contact Georgia HITEC support. Additionally, each second and fourth Tuesday at 12:30 p.m., Georgia HITEC hosts virtual office hours. This is an opportunity for you to dialogue directly with Ms. Hanson and Ms. Nelms regarding all of your QPP queries, questions, and you can definitely glean from their expertise. On behalf of the Georgia Health Information Technology Extension Center, we thank you for your attendance in today's webinar, and we hope that you have a wonderful afternoon.